Hello and welcome to this program, Hope Insight, being brought to you by Sankara Foundation. And it's a lovely concept. I would like to thank Team Sankara, especially my good friends, Dr. Muli Kaushik and Dr. Saptagirish, for giving me this opportunity. And this is in celebration of World Sight Day. My name is Rashmin Gandhi. I'm joining you from Hyderabad. I'm a consultant neuro-ophthalmologist at Center for Sight, Hyderabad. I'm also a director at Foresight Worldwide. And I had my neuro-ophthalmology training with Dr. Neil Miller at Wilmara Institute, Johns Hopkins. Today's topic is going to be a fairly common problem that we all encounter in our day-to-day lives, pale disc or a disc edema. And my talk is going to be limited to what would you do next if you see a patient with a pale disc or if you see a patient with disc edema. We're not going to go in great details about management, but what are the next steps for you to arrive at a conclusion as to what disease entity would have caused a problem that you're seeing. So let's look at the first case. We are going to navigate this by having some real life scenarios. So for example, you are seeing this patient, a 34-year-old male who has come to you for routine ophthalmic evaluation. No ocular problems, no visual symptoms. His Snellen's visual acuity is 6/6 and 6. But when you look at the fundus, this is what you see. And if some of you who are watching this, and if you feel that there is a disc which is looking a little pale here, I would agree with you. If some of you say that even this disc is not looking too good, I would not disagree with you. So here we are. Patient who has come for routine examination, and what you find is a disc color which is not appearing normal. What would you do next? So first question, of course, because patient does not have a problem, patient does not have any history which suggests that he would have had a pale disc because of some past episode. First question, of course, is this really a pale disc or is this something else we are looking at? And one short way of determining whether this disc is really pale is to look at the past medical records. If you knew that this disc looked pink in the past, if the patient has a previous disc photographs or your examination record, and if it said that disc was not pale, disc was pink, and now you're seeing this, you know that you're looking at a pathological disc, you're looking at a real disc pallor. So first thing first, past medical records will help you when patient is completely asymptomatic or has no symptoms which could attribute to appearance of the optic disc which is not normal. The other important factor to look at when you are in this query is lens status. Remember, presence of nuclear sclerosis might alter the appearance and the color of the disc, the way you perceive it, or presence of aphakia or pseudophakia also would do the same. So go back and look at the lens status and see whether what you're looking at is it an anomaly of a refraction or is it really an anomaly of optic disc. Examination techniques, if you're using a very bright light source indirect ophthalmoscope with more than 2000 lux, you might actually end up altering the color of the optic nerve because of the bright light going in. And other anomalies mimicking pale disc like myopic disc and whatnot. So if you have done all that and you're still not, you don't have a conclusion whether this disc is really pale or not pale, then we go ahead and perform the optic nerve function test. The most important and the objective optic nerve function test is RAPD. Perform the swinging flashlight test. If you find even a minutest of RAPD, you know that you are looking at a pale disc with an optic nerve dysfunction. You will find RAPD in all patients who have a unilateral optic nerve problem or asymmetrical bilateral optic nerve problem. So presence of RAPD confirms that what you're looking at, a disc pallor, is a significant disc pallor, a disc pallor which is pathological disc pallor. Color vision is an important optic nerve function test. It helps you to tell whether a patient has an optic nerve dysfunction. It also helps you to differentiate an optic nerve dysfunction because of ischemia versus inflammation. Presence of a visual field defect, red desaturation, present a red colored object first between two eyes. The patient looks at the red color object, you perform alternate cover test and ask the patient whether the red appears different in any of the eyes. If patient says the red appears washed out or it appears brownish or blackish in the eye where you suspect the patient has a pale disc, you are probably looking at an optic atrophy, which is of significance. Brightness sensitivity is done the same way. You have a torchlight, again perform an alternate cover test, ask the patient to look at the torchlight and see whether he perceives a brightness to be different in between the eyes. Patient with a suspected pale disc, and if a patient says that brightness is lesser in that eye, you're looking at an optic nerve which is not normal. And then formal fields. So we are looking at a scenario number one where you found a disc which looked abnormal, but there are no patient symptoms to back up that appearance. You go ahead and check the past medical records and perform optic nerve function test. If optic nerve function test comes back abnormal, you need to investigate it further. If past medical records shows the same disc, let's say 10 years ago, and optic nerve functions are normal, then probably you're looking at an optic nerve which is just appearing pale, but there is no loss of neurons. If you're still in doubt, OCT can help you. A patient with a suspected pale disc, and if you find that the OCT is showing RNFL thinning, you're looking at a pathological pallor. So to conclude, the first scenario, pale disc, no past history, questionable pallor, perform optic nerve function test. Let's move on to question number two, case number two. This is a 46-year-old female who comes to you with a loss of vision now for the last 6 weeks. Visual acuity is 6/12 in the affected eye, the other eye is normal. So here you have a patient who has a visual symptom. And what you find here is the left eye has, you see there is a blurred disc margin here with a hemorrhage on the surface of the disc. And if you look at the right eye and if you say that right eye also appears pale, I would agree with you. So now what would you do? There is a middle-aged patient comes to you with the visual symptoms, there is an optic nerve dysfunction. So what would be your clinical diagnosis and what next? To look at that, let's look at all different kinds of all different kinds of pathologies which can present to you with optic neuropathy. It can be inflammation, optic neuritis, ischemic optic neuropathy, compressive lesions, nutritional optic neuropathy, or hereditary optic neuropathy. These are the broad group of disorders which can present to you with optic neuropathy. So let's see whether this 46-year-old female who has come to you with an acute painless loss of vision, can it be hereditary optic neuropathy? The answer would be no. Because hereditary optic neuropathy generally tend to be bilateral, would have a gradual onset and would be progressive. Please remember, though hereditary optic neuropathy generally would start early in life, but there are hereditary optic neuropathy which can start a little later, even in second decade, third decade, or fourth decade. So that's point number one, and that's the reason why I would say that this is not, this does not appear to be hereditary optic neuropathy. The only hereditary optic neuropathy which can cause an acute or subacute loss of vision would be LHO and Leber's hereditary optic neuropathy, but that's generally seen in males. Presence of a full-blown clinical disease of LHO in female is extremely rare, so all practical purposes will say that hereditary optic neuropathy is ruled out. And same will go for nutritional or toxic optic neuropathy. Both would have generally a bilateral presentation, generally a gradual onset with a progressive course. There are instances where you may have a subacute loss of vision, but then you'll have a history, especially let's say methanol toxicity or ethambutol toxicity rarely can have a subacute onset, but then you'll have a very clear history for you to guide. Same again for compressive optic neuropathy. Most of the compressive optic neuropathy would have a gradual onset and a progressive course, not an acute loss of vision. Rarely, if the tumor is present, sitting there, and if there is a hemorrhage, there is a bleed in a tumor, then patient can present with an acute loss of vision. By and large, for a clinical perspective, a 46-year-old female with an acute loss of vision, you're looking at inflammation or ischemia. The age goes more in favor of ischemia, though please remember the newer markers have told us that there are optic neuritis who can present even in the 40s and 50s, like MOG and NMO antibody related optic neuritis can present to you even in fourth or fifth decade. They'll have pain, they'll have an acute loss of vision, and there'll be fluctuation. And because of presence of those entities, you would have to do MRI if you're not very sure. The other eye also has a small disc with a small cup in this. So you're probably looking at non-arthritic anti-ischemic optic neuropathy. What next? In most instances, the treatment of NAION is controversial. What we have to do is to manage the risk factors to make sure that the other eye or the other organs in the body don't get affected because of the vasculopathic risk factors. And 30 to 40% of these NAION can have a little up and down course for the first 6 months. It's like a stroke of an optic nerve. So most important thing on our part is to involve a primary care physician and make sure that the vasculopathic risk factors, which generally causes non-arthritic AION, are controlled. These are the things that we end up doing. Look at sleep apnea and see whether the patient has an obstructive sleep apnea. And if so, it can be treated because sleep apnea is associated with ischemia in the body. In a male patient, you will advise them to discontinue erectile dysfunction drugs if he's taking one. Amiodarone is associated with a syndrome which is like NAION. So amiodarone ideally should be substituted and smoking should be stopped. So that was a case scenario of presence of disc edema and a pale disc in presence of clear visual symptoms. Please remember, in most instances, NAION would have an acute loss of vision and vision will stay there. Rarely, there can be a progressive loss of vision for a couple of months or more in patients with NAION, and these are the patients where you should get the renal function test done because patients with nephropathy can have a progressive loss of vision even in the presence of ischemia. So that was scenario number 2. This is scenario number 3. Now, a similar kind of presentation, but a 70-year-old female, sudden painful or painless loss of vision, profound loss of vision in the affected eye. What you're looking at here is a clear disc edema, and you see here there is actually a nerve fiber layer infarct even in an acute stage. If you look at the other eye, so you're looking at 70-year-old female with a disc edema and a profound loss of vision. You always look at the other eye and see whether that cup is normal. If the cup is not normal, if there's a crowded disc, you might still be looking at a non-arthritic ischemia. But if the cup is normal, 70-year-old female, presence of headaches, acute nerve fiber infarct on presentation, this is what is described as pallid disc edema. Pallid disc edema is not seen in all ischemia cases. It is generally seen in arthritic variety of ischemia where there is a sudden massive infarction of the nerve fibers and optic nerve. So this is an emergency. You ask for history of weight loss, headaches, polymyalgia rheumatica. Get ESR, CRP platelets done immediately, and these patients would require steroids immediately because you may or may not be able to help the eye which is already infarcted, where the optic nerve is infarcted, but the reason why you are administering steroids is you want to make sure that the other eye does not get affected, which can be affected within few hours of the onset of ischemia in one eye. And you also want to prevent a similar ischemic attack in the other organs like heart or brain. So remember, what you need to do is ESR, which would be very high in arthritic area. You can also look at this picture and you see that patient also has BRAO. So these are also associated features which will be seen in somebody who has an arthritic variety of ischemic optic neuropathy. So pale or swollen disc in the setting of ischemia, you first have to differentiate between non-arthritic and arthritic variety. Non-arthritic variety is generally seen in patients below 60. Arthritic variety is generally seen in patient who is above 65. In Indian population, arthritic AION is not that common. This is a first attack, progressive attack, or recurrent attack. If it's non-arthritic, as we discussed, make sure that vasculopathic risk factors have to be controlled. We move on to the next case. This is a 25-year-old female, a 25-year-old male with a gradual progressive loss of vision in the left eye for the last 6 months. His visual acuity in the left eye is 6/60. He had a minor trauma in the left eye and he was told that the pallor, and you can see there is a pallor of the optic nerve, the pallor and 6/60 vision, he was told, is related to the trauma that he had. But if you look at the optic disc carefully, what you'll find here is the poles, superior and inferior poles are fairly pink, while in the nasal and the temporal raphe, the discs are pale. So this is an example of a band-shaped or a bow-shaped optic atrophy. And this is generally seen in chiasmal compression. A bow tie optic atrophy is a feature of chiasmal compression. What you require in this patient is the field of the other eye. This eye, you may not get a good information because patient has 6/6 vision. He may not be able to do fields very well. But what you find here is that the other eye, you have this very small defect, but it is respecting a vertical midline and it's in the temporal quadrant. So this is an example of a junctional scotoma. And this is, again, as I said, is seen in chiasmal compression. This patient would require MRI scan of the brain and orbit. And what you'll find here is in this patient had, you find here pituitary adenoma, which is seen here on this MRI scan, which is there on the right side. So pale disc in the setting of progressive loss of vision, two important things, other eye fields. And whether other eye fields shows an anomaly or does not show an anomaly, if the patient says that he has a progressive loss of vision, it does not matter if in that eye patient has an optic atrophy, patient should get a neuroimaging. Because a progressive loss of vision, there can be a compression which is there, which is now expanding, and you can treat it. This is the last case for the day. This is a 28-year-old female, now is complaining of both eyes, gradually progressive loss of vision for the last 6 weeks, associated with headache. The visual acuity is not too bad in one eye, but in the right eye, vision is 6/24. And when you looked at the fundus, this is what you found. You found that there is a pale, or this is a disc edema in both the eyes. The left eye is appearing a little pale, which is confirmed by FFA. So you have a 28-year-old female who is slightly overweight. She's complaining of headache and has bilateral disc edema. Also now, recently, she says that her vision is going down. This is again an emergency. If the patient does not have a neuroimaging, you should get the neuroimaging done, because what you're looking at is raised intracranial pressure with bilateral disc edema. So before you move on, there are a few clinical points that I want you to look at. You should always ask for, apart from history of headache, there are two important symptoms that you should ask for. One, history of transient visual obscuration. Remember, papilledema causes transient visual obscuration which lasts for a few seconds. It is generally described as browning out of vision, and it is related to posture. This is as opposed to transient visual obscuration, which is seen in a vascular event in thrombus, where generally it lasts for a few minutes. While here it will last for a few seconds, and you will find that it's associated with postural change. The second important symptom you should ask for is tinnitus. These patients may complain of tinnitus, which is typically described as a whooshing sound in an ear. The third important symptom or third important feature you want to look at is a recent weight gain, because that's generally associated with raised intracranial pressure of IIH. But IIH, please remember, as the name suggests, is the diagnosis of exclusion. You label it as IIH when you didn't find a cause for raised intracranial pressure. Please also remember the term BIH has been obsolete. There is no such thing as benign intracranial hypertension, because it is the raised intracranial pressure is potentially a blinding disorder. So what investigation would we like to do is generally MRI with MRV. Why you're doing MRV? Because you want to look at the venous sinus thrombosis, which can be a cause or effect of raised intracranial pressure, and that is treated differently. The cerebrospinal fluid in IIH would be normal except raised elevated opening pressure. So these are the signs and symptoms that we mentioned, that there is a pulsatile tinnitus and TVOs, transient visual obscuration, which are posturally related. Papilledema in an acute phase would have a visual field defect, which will be generally enlarged blind spot. A chronic papilledema, raised intracranial pressure, which is not treated for a long time, would cause a chronic papilledema, and that will have ring scotoma in both the eyes. One of the differentials for ring scotoma is chronic papilledema. And what are the treatment options if patient has a raised IC? Please remember, if a patient comes to you for the first time, and if she is not neuroimaged, then first thing first, you have to make sure that you get the neuroimaging done. MRI brain and orbit with MRV is the neuroimaging of choice. And the treatment options for these patients, most important thing which we forget is weight loss. Patient should get at least 15 to 20% of the baseline weight he or she should lose in the first 6 months. Acetazolamide is the cornerstone of treatment. A lot of times we start the treatment or a neurologist would start the treatment. Uh, Initially, patient may require a little higher dose of acetazolamide to bring the pressure down and then put them on a maintenance dose. Other medical treatments like diuretics have been tried. Surgery. The optic nerve sheath fenestration has been a treatment option which has been tried repeatedly. Please remember, in an acute phase or patient intolerant to amox, this is a good vision saving procedure, but the long-term effects of optic nerve sheath fenestrations are debatable because whatever opening that you make in the optic nerve sheath, it gets closed, like the way it happens with trabeculectomy, where the ostium gets closed. So here also ostium can get closed and patient can have a subsequent rise in pressure. So at least in acute phase, you are taken care of the pressure. The other surgical option, which is generally administered by neurosurgeons, would be the shunts. The shunt procedures are generally reserved for patients who have more predominant neurological symptoms like headache versus a visual impairment. Patients who have predominant visual impairment, progressive visual impairment, optic nerve sheath fenestration is the treatment of choice. So to conclude, if you see a patient with pale disc or a disc edema, the first step that you have to look at is this really a true pale disc or a true disc edema? Second thing in both instances is look at the symptoms. Does the patient have a progressive loss of vision as the presenting feature? That will require an aggressive investigation because patient has a disease process which is still there, which is going on in his nerve or in the brain or in the visual pathway. The third important part is optic nerve function tests. RAPD, color vision, and visual fields are important optic nerve function tests which have to be performed, which will give you a clue as to why patient has a pale disc or a disc edema. In a progressive or a recurrent problems, patient should get an appropriate neuroimaging like MRI brain in orbit with contrast, fat suppression if you're looking at an optic nerve problem in the orbit, or with MRV if you're looking at a raised intraocular pressure. And many of these, you might have to, after you've done these tests, you might have to go to Humphrey's visual field and OCT for monitoring. And you would have to also involve the neurologist at an appropriate stage because a lot of these patients would be treated in partnership with neurologists. With that, I would also like to thank Sankara Academy of Vision once again for giving me this opportunity. Thank you so much.